Thank you for taking the time to join us this afternoon for our latest installment of the Havey Institute for Global Health First Friday Seminar Series. And today's title is Sexual Behavior Repertoire in Sub-Saharan Africa and Risk of HPV Infections and Associated Cancers. Please take a moment to follow us on Facebook and Twitter, hashtag FSM Global Health. In addition, we welcome you to become an Institute member, very easy to do, and you will receive access to specialized resources and services that support research infrastructure. For more information, please visit our website at globalhealth.northwestern.edu/members. Today, we're very happy and thrilled to have Dr. Imran Morhason-Bello join us. Dr. Morhason-Bello had his undergraduate training in medicine and surgery and a master's in reproductive biology at the University of Ibadan in Nigeria. He has a master's in public health and epidemiology from the University of Liverpool and a PhD from the London School of Hygiene and Tropical Medicine in the United Kingdom. He's a fellow of the West African College of Surgeons and a National Postgraduate Medical College in OB-GYN and a fellow in the International College of Surgeons. He was awarded Doctor of Medicine at MD degree in the National Postgraduate College, Nigeria. He's currently a senior lecturer at the College of Medicine, University of Ibadan, and honorary consultant at the University College Hospital, or typically referred to as UCH. That's also in Ibadan. He also lectures master's and doctoral students at Pan-African University Institute of Life and Earth Sciences at the University of Ibadan, one of Northwestern's major partners. Following the presentation, there will be time for questions, and which will be led by Dr. Li Feng Ho, and we welcome you to submit your questions in advance, preferably through the Q&A feature at the bottom right-hand corner of your screen. You can do this at any time during the presentation, and Dr. Li Feng will lead the discussion. So now, Imran, I turn it over to you. Thank you very much for joining us today.
So I'd like to ask everyone to mute yourself when the speaker is speaking.
Thank you very much, Rob, for introducing me to give this talk. I will start by sharing the outline for my presentation this afternoon. Or this evening, since I'm speaking from Nigeria. I will talk briefly, give a synopsis of Sub-Saharan Africa. I will talk about sexual behavior repertoire, discussing different definitions and their coverage, and then of course the concept of sexual risk behaviors. I will look at non-penile vaginal sex within Sub-Saharan Africa. And then I will look at connections between human papillomavirus and associated cancer using global and sub-Saharan data. And then, of course, I will end my discussion by sharing our experience of recently conducted studies on sexual behaviors and associated HPV infections in Nigeria across different populations. And I'll end my discussion with recommendations and conclusions. I would like to start this presentation by thanking the leadership of Havey Institute of Global Oncology, Northwestern, ably led by Professor Rob Murphy. And I would also like to thank Professor Li Feng Ho, both of whom have had connections with my mentor in Nigeria, Professor Isaac Adeoye, who is incidentally here this evening with me to give moral support. I've also seen another senior member of academic, my department, Professor Akin Kawamibodun, and other people. So I appreciate you, and I hope we'll enjoy the session. So I would like to say that Africa is highly heterogeneous. We are people of diverse colors, culture, language, belief, and social system. We often take pride in the huge population that we have. Sub-Saharan Africa have over 1 billion population. Of course, there are some challenges in terms of poverty level, low literacy level, and of course, most of our health outcomes are below average. And of course, we are also having challenges of infection rate. But in spite of these challenges, we're blessed with different natural resources. Coupled with these natural resources, there are conflict areas. Many of the countries have unstable polity, but above all, there are a lot of brilliant mind and hardworking people within Sub-Saharan Africa. So it's not usually a tale of woe when you hear Sub-Saharan Africa. So Sub-Saharan Africa has a huge young population relative to United States or any of the high-income countries because of a relatively lower life expectancy. And of course, this has implications with respect to sexual health and other associated non-communicable diseases. So what is a sexual act? I know within different cultures, there are legal definitions, there are social definitions, and in fact, there are scientific definitions. So if somebody said, I've had a sexual act within Sub-Saharan Africa, oftentimes they think of penile vaginal sex. But things are changing now that there are non-penile vaginal sex in terms of contact between the mouth and any part of the genitalia, using finger or any object to touch the genitalia or even any other part of the body to elicit erotic feelings or even romantic feelings. And of course, the concept of using artificial substances or objects to stimulate. So this is often different from sexual touching, which oftentimes comes with legal implications. So there are other parts of the body that when individuals touch it, it may not scientifically mean sexual activity has taken place in terms of sexual related risk. So one needs to be very clear in terms of what one is trying to describe. So in terms of the different sexual behaviors that I will talk briefly, I will look at the penetrative sexual behavior and non-penetrative sexual behavior. And then, of course, I will also look in terms of different types of non-penetrative sexual behaviors, which includes masturbation, sexual toys, and other forms of sexual activities. So when we use the term sexual risk behavior, there are different definitions that has been given over the years in terms of, particularly with the advent of HIV/AIDS, in terms of understanding what is sexual risk behavior or risky sexual behavior. Oftentimes, most literature from Sub-Saharan Africa discuss around penile vaginal sex to profile individuals that have had risky sexual behavior or sexual risk behavior. But there are limited data with respect to anogenital sex or orogenital sex because largely most of the countries within Sub-Saharan Africa have restrictive law and culture with respect to non-penile vaginal sex. Other important attributes of sexual risk behaviors include early sexual debut, multiple sexual partner, that is having more than one sexual partner, having a high-risk partner, that is someone who has multiple sexual partner or who has had recent STIs, or sex with a partner who has reported ever injected drugs, or even commercial sex workers, or someone that has engaged in transactional sex. So the concept of sexual risk behavior also holds around sexual networking. When you have sex with someone, you're having sex with everyone they have had sex with. And with everyone they have had sex with, and that may continue in either arithmetic or geometric proportion, depending on the risk of individual that someone has had unprotected or condomless sex with. So there are evidence from different national sexual behavior related surveys in high-income countries, but one of the large data from UK and the US, but I'm sharing for this presentation, I'm sharing data from the UK. The NANSAL data did show that within a space of about 10 to 20 years, the proportion of young people engaging in vaginal, oral, and anal sex between 16 and 24 years doubles, and it becomes there's an 100% increase between 1991 and 2012 cohorts. And this has also been shown to have a generational effect, even within the same cohorts of NATSAL survey. That is, younger generation tends to engage more in unprotected oral and anal sex compared to older generation. So we all know that sexual behavior, I mean, the globe is, Sub-Saharan Africa is located within the globe. And of course, we know that the whole world has been linked together with technology and other platforms. So penetrative and non-penetrative sexual behavior has also been reported one way or the other in Sub-Saharan Africa, despite the limitations in terms of opportunities to have access to westernized materials that are often linked with other non-vaginal sex. So we conducted a systematic review of published articles up to 2018, and one of 133 studies that reported non-penile vaginal sex, that is oral and anal sex. Only 4 of these studies were able to give the operational definition of oral sex, which I will talk a little bit more in terms of sexual health risk implication of engaging in oral sex. So you want to know whether individual received an oral sex or give oral sex. The same thing with anal sex, because this risk is in terms of risk of acquisition or transmission of infection, sexually transmitted infection, they are different. So most of the studies reviewed will just say, oh, we ask questions about oral sex. So we do not know whether in fact, what type of oral sex these people had, whether they gave oral sex, whether they received oral sex. So this is very, very important. And I will quickly show some related data. So this is the data that the studies that were that we looked into, disaggregated into regions. You see that majority of the data show that most of them just reported oral sex in terms of prevalence. They didn't disaggregate the data into whether it was insertive, that is, gave oral sex, or received oral sex, which were very, very sparsely distributed within this graph. And if we look at it in terms of disaggregating it between general population and key affected population, which are the people that we often call the high-risk people, such as HIV positive individuals, female sex workers, men engaged in heterosexual relationship, or they also have other form of sexual relationship. So you will see that most of the studies also reported oral sex within, in terms of, did not disaggregate in terms of insertive or receptive. Similar pattern exists between, for the anal sex. You see that most of the studies reported both within the general population largely, but among the key affected population, a lot of studies disaggregated the data into whether it was insertive or receptive. But let me say that this review was limited to people that reportedly engaged in heterosexual relationship. So what is reported here is heterosexual anal sex. So the review did not cover those that are in same-sex relationship. So, but after the review, there was another large study that was done in Côte d'Ivoire called Okapi cohorts that recruited over 700 participants. It did show that oral sex and anal sex were roundly common among the general population. And in fact, a lot of them initiated this sex ahead of penile vaginal sex. Now, looking at oral sexual practices among men who have sex with men, and of course, transgender women that are at risk of living with HIV/AIDS in Nigeria, you see that a lot of people engage in any form of oral sex have increased odds of having any form of sexually transmitted infection in their oropharynx. And there is also a weak association, because if you look at the lower confidence interval here, is close to 1. So you see that there is increased odds of having oral gonorrhea, oropharyngeal gonorrhea, oropharyngeal chlamydia in those that have reported any form of oral sex. But what will have been important is to find out whether the risk changes with the type of role that individual played during the oral sex. That is, whether the individual received oral sex or gave oral sex. So what is also worrying is that penile anal sex within Sub-Saharan African setting, people have poor knowledge about the health implication of engaging in it. A lot of women that reported heterosexual anal sex do engage in it without any form of lubricants. And of course, most of them are condomless. So thus increasing their risk to sexually transmitted infection, including human papillomavirus. So as a form of introduction for particularly those that are not familiar with human papillomavirus, human papillomavirus is one of the commonest sexually transmitted infection. It can be transmitted via sexual activity, largely if it is unprotected. But there are other form of non-sexual transmission via skin-to-skin contact and via vertical transmission from mother to child. And the virus has predilection for epithelial mucosal surfaces. About 13 human papillomavirus from about over 200 high risk. And these are the cancer-forming one. And the commonest oncogenic type is 16, followed by 18. Now, HPV, in terms of, is mostly acquired and transmitted via sexual contact. And irrespective of potential discriminatory factors, the risk is there. And the risk of HPV is higher than that of HIV and other sexually transmitted infections. Human papillomavirus infects young people, and 80% of people will have had it at least one form or the other in their lifetime. Majority of people will clear the infection. And it's important for one to understand how human papillomavirus progress to cancer. And one of the most evident natural history of HPV infection is the natural history of high-risk HPV infection in the cervix. HPV usually affects transformation zone. This is usually the location between the old squamocolumnar junction and the new squamocolumnar junction in the adult. Most of the time when they're during sexual activity following bruises, this virus get incorporated into the basal cells, and then following different biological mechanisms, which time may not allow me to explain, these cells inhibit materials or molecules within the cells that regulate cell division. And then this cell division that is usually regulated is now left to be mortal. And then these cells begin to divide in an uncontrolled fashion, and then undergo the process of, in other cytology, what we call dyskaryosis, and in tissue cells, we call dysplasia. And then, of course, when lower 1/3 is affected, of these cells are affected under the tissue, it is called CIN1, cervical intraepithelial neoplasia 1, and then when 2/3 is affected, cervical intraepithelial neoplasia 2, and then 3 when the whole cell layer is affected, and when there is a breach of the basement membrane, it becomes an invasive cancer. And this is the same pattern that is reported in other sites. In the mouth, in the oral cavity, in the oropharyngeal space, in the oropharyngeal area and the oral cavity, the pre-malignant lesions are recently classified as oral potential malignant disorders, and there are a couple of them. The chief among them is the leukoplakia and erythroplastosis leukoplakia. Other ones, for example, in the anus, anal intraepithelial neoplasia, in the vulva intraepithelial neoplasia, in the vagina intraepithelial neoplasia. So most of the time when HPV infection happens, a significant proportion of people clears it. Between 85 to 90% of people clears it. It's only very few people, 10 to 15%, and in higher proportion among those that are having immune suppression that fails to clear. And it's the persistence of this infection that leads to pre-malignant disease. And when nothing is done, this leads to an invasive cancer. So human papilloma virus or HPV-associated cancer is a necessary cause of cervical cancer because in almost 100% of cases, high-risk HPV is associated. It's 8 to 90% in anal cancer, 70% in vaginal cancer, and head and neck cancer, where oral and oropharyngeal cancer, at least 1 in 4 of that cancer is associated with high risk. Now, according to the recent global data, human papilloma virus is the next commonest cause or is the next commonest infection-related cancer following Helicobacter, that is over 800,000. Now, if we look at this data by continent, Africa alone contributes about 24.8% of HPV associated cancer to the global body. Now, within Africa, about 130,000 people have HPV associated cancer within the continent. And East Africa has 56,000. You can look at it, West Africa, 34,000, and Southern Africa, 16,000, and Central Africa, 14,000. Now, when you compare Sub-Saharan Africa to the rest of Africa, that is cutting off the Northern Africa, you see that cervix alone contributes 24%, that is a quarter of all the HPV-associated cancer. Now, in terms of looking at the projection, there is a recent data that shows that if nothing is done, because of the changing sexual behavior in Sub-Saharan Africa, oral cancer, oral and oropharyngeal cancer will increase astronomically by 2050. And then looking at Sub-Saharan Africa, another peculiarity is that we have one of the highest burden of HIV globally. There was a review recently that showed that there is increasing risk of HPV-associated cancer in people that are living with HIV. And the risk ranged between twofold to as high as 22% fold, depending on the population of HIV population that is reviewed. Even for vulvar and vaginal cancer that we think is rare in Sub-Saharan Africa, the available data, this show that vulvar and vaginal cancer occur in younger population among people living with HIV compared to non-HIV population. So having looked at the pattern of sexual behavior, looking at the burden, then can we look at the current evidence that we have based on our efforts in Ibadan? This was a study that was conducted between, it was a partnership between Ibadan and the London School of Hygiene and Tropical Medicine. And the study was entitled Sexual Behavior and HPV Infection in Nigerians in Ibadan. The study explored this knowledge and sociocultural interpretation of how sexually active people engage in different forms of sexual behavior, what are the motivations, attitude, and how potential health risks are understood, and including stigma among these people. And then we tend to look at the prevalence, we look at the risk factor analysis, and look at concordance across multiple anatomic sites in the same person. So this was a mixed method study. The qualitative was more of a formative, conducted about 18 focus group discussion and 36 in-depth interviews, and cross-sectional studies were household survey that were conducted in an urban center and a rural center, a peri-urban center, and within 28 brothels in Ibadan. So a face-to-face interview, clinical examination, and biological sample collections were done at the clinic in a public primary healthcare setting within the community after we have mapped the community and we developed a cadastral or geospatial map of the area. We used an Aniflex 28 assay to test each of the sample collected for 28 HPV types. And then we did some analysis. So this was a summary of how the recruitment was done. We selected enumeration area by population proportion to size. We conducted census of the houses and the household. Then we did a systematic random sampling of eligible participants within each of the clusters that were picked. And then, of course, a home visit was conducted. Participants were invited to the clinic to participate in the study. And then, of course, this is the 5 activities that happen in the clinic. Now, in the brothels, what happens is that because we had done a qualitative study, the sex workers believed that, wanted that their room to be converted to the clinic. So we operated a mobile clinic where their room were used as clinic for sampling among the eligible participants. And this was the conceptual framework. We tried to look at association between, we look whether sexual behavior, lifestyles, social-cultural factors could influence risk of acquisition of HPV infection in any of the 5 anatomic areas, in any of the 4 anatomic areas in women, and then of course in 3 anatomic areas in men, which is penile, oral, and anal. I must say that these people reported to be engaging in heterosexual relationship. This is just to give us a little brief about the study site. Ibadan is the capital of Oyo State, located in southwestern Nigeria. So what are the key findings? So from the qualitative study, we did notice that the awareness, knowledge about heterosexual, oral and anal sex was influenced or were influenced by generational gap. Younger people tend to be aware of oral and anal sex activity within an heterosexual relationship. And of course, most of them did say that they got this information through watching sexually explicit materials. And of course, a lot of them had motivation to keep their relationship. A lot of them engage in it for financial reward. Some of them engage in it as an alternative to vaginal sex. This alternative to vaginal sex were in the context of when they were menstruating, in the context of maintaining their virginity, and then in the context of exploring adventure. And of course, those that reported financial reward were more among the sex workers because they were able to negotiate for better price when individual asked for oral or anal sex. And then the younger people were more familiar with slang terms to covertly discuss oral and anal sex within the family or within their environment in order to cut off those that may not necessarily be aware. And this is what this cartoon is saying. What are the other words for sexual act? Intercourse, coitus, but of course, lovemaking. These are ones that we know, but of course, I'll show you now that there are a lot of terms that many of them were using in order to prevent their guardian, particularly young people, from understanding the discussion. So these are some of the slang terms. There are slang terms when a man gives oral sex, and there are slang terms when a woman gives oral sex. There are slang terms for oral sex when it is used interchangeably. That is, when it is used interchangeably, it may be difficult for you to know. For example, if somebody said, "Oh, I sucked yesterday," without using "I," it may be difficult for you to know whether he was the one that sucked or he was sucked. But if somebody said, "I licked plate," it shows, I mean, their interpretation is that, oh, okay, individual must have a male partner may have used his tongue to touch the genital of a lady. And of course, the slang term for penile anal sex. When we were probed, why were they using these terms? He said they use it to protect themselves when they are having sexual discussion with their friends at home in order not to know, in order to prevent their parents from understanding the discussion. So let me quickly share some findings from our community and brothels, data that we collected. We observed gender differences in oral sexual behavior. Male participants generally were more likely to have ever reported or received oral sex, and they are also more likely to have, in fact, they are 3 times more likely to have ever received and to have ever given oral sex relative to females. In terms of high risk HPV, what we found among women in the general population, the 310 of them, HPV 35 is the commonest high risk, and the lower, the commonest low risk is 42. If you look at in terms of vulvar HPV, HPV 35 is the second commonest after HPV 35 is the commonest, followed by HPV 33. The same thing here, HPV 35 is the third commonest after 52 here in anal. Now, HPV 35 is second to 51 here. Now, among the female sex workers, the 315 that were recruited from the 28 brothels, HPV 35 is the commonest high risk in the cervix. HPV 35 is the commonest in the vulva. HPV 35 is the commonest in the anal, and HPV 35 is the commonest in the oral among those that have HPV. Now, if you look at the prevalence, point prevalence, you can see here that, but what is important is the high risk population. Now, you can see that nearly half of women in the general population have high risk HPV in the cervix, in the vulva, average, over 1 in 3 and 1 in 10 have high risk HPV in the oral. And risk of multiple HPV also is associated with likelihood of developing cancer. This has been shown by several studies. And you can see here that about 1 in 3, about almost nearly 1 in 3 or above 1 in 3 have high risk, have multiple cervical, vulvar, anal HPV. And then of course, about 5% of them have multiple HPV. Now, among the female sex worker, this is higher. In fact, is in multiple proportion among them relative to women in the general population. And you can see that almost two-thirds of them have multiple HPV infection. And if you look at high risk, over 70% of them, or 70%, 75%, and then 60% have anal high risk HPV infection, and 15% have high risk oral HPV. And of course, about 1 in 10 of them has multiple HPV infection in their mouth. And of course, you can see that there were significance in terms of trend across age group, with highest proportion in younger population in most of them, with the exception of the oral samples. So when we did a risk profiling, what is important? There are so many areas that are of interest. But for this presentation, because of my subsequent slide, I want us to focus on the biological factors. So if individual has HPV in a site, it increases the odds of having it in another genital site. And this is evident by this data here. The odds can be as high as 21 in vulva, about 13 in the cervix. And then of course, if somebody has cervical HPV, the odds is almost 4 with oral HPV infection. And this is among, what I just showed is among general population. Similar pattern among the female sex workers in the general population. Having HPV in one side is a risk factor in another side. But what is also important here, oral HPV is more common in HIV positive population, and it's about 2.4, the odds is 2.4 higher than in non-HIV population. Now, what about men? Now, we also look at women, men in the general population. Penile HPV, these are men that are around 310 of them. High risk, the commonest is also HPV 35. If you look at the anal, HPV 35 is still is about the same level with that of HPV 56. And of course, HPV 35 is second in the oral after HPV 39. So again, you can see that the high risk HPV in men is relatively lower compared to women in general population, but about 30% of them or 31% of them have it in the penile, in the anal, and very low level in the oral because relative to women in general population. And then of course, having it in the penile also increase the odds of having it in anal and vice versa. So now another interesting finding from this study is having when individual has HPV high risk or HPV in the site, there is a higher chance of having similar genotype in another site, meaning that this may have a public health implication that if an individual has a high risk HPV in one site, you may need to search other sites for likelihood of having another high risk in another population. So, but this the concordance has been explained from two different theories. One is the viral shedding, and that may explain the reason why there is high concordance between the cervix and vulva. So for any high risk and for any low risk in women and in female sex workers, relative to other sites. But people are saying that, look, it cannot explain what happened by having concordance in genital site in oral, for example, or oropharyngeal site. So there may have to be other explanation in terms, and this may need further research activity in terms of looking at other biomarkers that could predict this biological mechanism. So could sexual behavior influence this? Could people be engaged in what we call mutual masturbation? There are a lot of people that masturbate and at the same time, without washing their hand, use their hand to touch their saliva, put their hand back, and the movement of hands between those two sides could elicit or could increase the risk of acquisition of this infection across this site. Similar pattern is also observed in men. And of course, what is important is there's concordance, high concordance between penile and anal in men. This may also be explained from concept of viral shedding and concept of other form of sexual behavior that may not necessarily be declared. So what are the key messages from these findings? The findings shows that unlike what has been previously reported, that non-penile vaginal sex is not common in Sub-Saharan Africa. A lot of people are engaging in it. We may not have been asking the right question. By the way, the tools that were used for this study was adapted from NATSA. So we clearly defined what is when somebody is giving an oral sex. We clearly defined simple definition of when somebody is receiving oral sex. Simple definition when somebody is giving anal sex, and simple definition when somebody is receiving anal sex or any form of sexual activities. But we also found that there's high concordance of HPV in one site compared to other sites. So now, because of the high body, because this talk will not be complete without me talking about HIV and HPV connections and HPV-associated cancer in Sub-Saharan Africa. Now, there are two studies from Nigeria that's of interest to me when I was preparing this. The first was a study conducted in North Central Nigeria that looked at the risk time to clearance of HPV infection by HIV status. Even though non-positive HIV negative individual tends to clear, but the time to clearance was between HIV positive and HIV negative was found not to be significantly different, but in the adjusted model, they found out that presence of an HIV positive population or having an HIV is actually associated with acquisition and clearance. Similar thing was also found by Hygiene in his own study that's conducted in Lagos that shows that there's increased odds, almost 2 times in the final model, that if individual is HIV positive, it's more likely to have a high-risk HPV in the cervix. If the person is not on ART, if the person has reduced CD4 count and increased viral load, particularly if it is more than 10,000 above. In another study in North Central by a colleague and friend who looked at high-risk HPV and cervical abnormality in HIV women with normal cytology. So I think the key message, my understanding, is that even when the cytology appears normal, it may be important for you to do a colposcopic examination if an individual is HIV positive, as shown in the final model here. Now, there was a landmark study that gathered data from about 3 different countries in Sub-Saharan Africa, nearly 500 participants that looked at HPV status of invasive cervical cancer across the 3 different countries, Ghana, Nigeria, and South Africa. What is interesting is that HPV 35 that was reported by most studies, recent studies in Nigeria as commonest across different sites, is the 3rd commonest single HPV associated with invasive cervical cancer. Unfortunately, HPV 35 is not covered by any of the candidate vaccine. And of course, it could be argued that cross-protection may be useful, but what is important will have been that we may need to begin to do advocacy to say that if there is going to be a new design of an HPV vaccine in future, apart from Gardasil 9, HPV 35 should be considered, because in a recent publication by the NCI, HPV 35 is also found to be very common in an African American population relative to other population in the US. So what are the drivers of HPV-associated cancer in Sub-Saharan Africa based on literature? First is that there is increased prevalence and or incidence of sexual risk behavior, but there is poor awareness and knowledge about the implication of engaging in this sexual risk behavior. There is a lot of misconception and myth around sexual non-penile vaginal sex, in terms of the fact that people believe that they are safer, they are not sexual, and they are not associated with any health implication. It also has a lot of socio-cultural interpretation. People don't want to talk about it. If someone had engaged in inner sex, it will take a lot of courage to be able to state it out within a Sub-Saharan conservative environment. And of course, lifestyle, where multiple sexual partner by men is seen as a form of a status symbol relative to women. Seeking behavior is also generally poor. The interpretation of healthy person and the concept of disease is not saying that, I mean, people don't generally feel that, okay, I need to go and see my doctor or go to the health facility for screening when I'm not having any incapacitating illness. So that culture has affected screening programs, even where countries strive to have a national program. And of course, there is poor understanding of connection between sexual behavior and health risk, which I have explained. There is also insufficient or complete lack of data to understand the body, biological mechanism, risk profiling, diagnosis, and treatment. Most studies that were conducted particularly on sexual behavior. Most of them, particularly in the review, were done with convenience sampling, which we call non-probability sampling. These have implication for generalizability. Many of them did not define their outcome. So, for example, if somebody kisses somebody, it may mean that, oh, I've performed oral sex. Meanwhile, that is different when somebody uses the mouth or any part of the mouth to touch the genital. Then there's also a challenge of social desirability effects, because many of these social sexual risk behaviors are not culturally acceptable. So people may be withholding information. So there's likelihood that many studies that have reported this sexual risk behavior may have underreported. There are many countries in Sub-Saharan Africa do not have national data for other forms of sexual behavior apart from vaginal sex that is covered in NDHS, that is National Demographic Health Survey. Yeah, there's an extremely low number of studies to understand the basic and biological mechanism of HPV-associated cancer. We do not have many longitudinal studies or randomized control trial that try to understand the mechanism for developing HPV-associated cancer. For example, it would be interesting to look at why do Sub-Saharan African population and African American population are having predilection for HPV-35 relative to other population groups. Now, the weaker system, there's lack of capacity, human resource, opportunity, and equipment are not there to offer comprehensive healthcare, including screening for HPV-associated cancer. And most countries in Africa, as I will show shortly, have not started vaccination, which is routine in most high-income countries. Many countries in Africa, in Sub-Saharan Africa, do not have national screening program. What we engage is opportunistic screening. And even the opportunistic screening, we are not using top-notch screening methods, including HPV testing. Rather, most countries are still engaged in visual examination with acetic acid or Lugos allele, which has a poor, relatively poor outcome compared to others. And then, of course, the treatment opportunity. And again, on top of this is that most countries in Sub-Saharan Africa do not have insurance to cover cancer care or cancer screening. And there's, of course, when patients notice something is wrong, for example, maybe a woman has postcoital bleeding or has bleeding, repeated bleeding from the gum, which may suggest an ongoing malignancy. Sometimes there is inefficient referral system. Many of these patients wander around. There are a lot of publications around this, that sometimes most patients that we often think present late in tertiary center for treatment actually present early in other arm of the health system. But it's just that they are wrongly diagnosed and treated or provide treatment before they eventually get to where they will be properly treated. So this is showing the apology for the poor quality here. You can see between high-income country and low and medium-income country, many countries in high-income country are almost having 100% female vaccination and above average male vaccination, because the concept now is to do what we call a gender-neutral vaccination to promote that. Of course, low middle income country are having less than 5%. The only country in Africa that has really gone far with respect to vaccination is Rwanda. My country is just planning to start a national vaccination program. Well, I hope one day this will be incorporated into the national routine vaccination exercise. So countries that have recently, 6 countries also recently introduced, you can see that most countries in Sub-Saharan Africa are bare, meaning that there are no vaccination program. It's not that there are no vaccine, people are getting it. Few people are getting it, few privileged people, I must say, are getting it for their children. But what is important for it to have a public health implication is to have a national rollout. So I would like to end by making some recommendations. One is that we need to create awareness on different sexual behavior and concept of safe sexual practices. We can use different terminologies. In restrictive countries in Sub-Saharan Africa, some countries will not want to hear sexual health or sex education or sexual health education program for young people as early as when they are in the primary, but people are getting away around it by calling it family life education program. We need to strengthen this health policy on sexual health policy and program. Many countries in Sub-Saharan Africa need to review their policy because many of these sexual health related policies were focused on penile vaginal sex as the risk that they are trying to prevent or manage. So we also need to generate data. This is long overdue, particularly now that countries are beginning to have national survey on HIV. We may need to lobby either the national group that are funding HIV program or demographic surveys across Sub-Saharan Africa so that data could be compared across countries. There's need to have a robust cancer control plan that will include HPV-associated cancer, which I've explained, behavioral change communication, vaccination, and screening. Single dose vaccination is what is recommended for low-middle income country, and point of care for HPV testing and triage and treat may be a game changer in Sub-Saharan Africa. And there are so many studies that are beginning to show this, that see and treat is feasible with HPV testing, and these may improve access. But of course, the issue of cost is still there. One way to cut costs is to also reduce pressure on the health system. Can we encourage self-sampling? There are a lot of implementation projects that has been funded in Sub-Saharan Africa. We eagerly await. Some of them have been published, but more are on the way, and we eagerly await the outcome. There is also need to have a sustainable access. It's not only providing this treatment, we also need to make it sustainable. And how do we make it sustainable? By ensuring that everybody have access. I'm not very sure that of many of countries, for example, in Nigeria, there are a lot of, I remember that recently I was asked by Professor Adewale that whether Nigeria will start a national program, and we discussed it among ourselves that time. And of course, what is happening is that it is there in the document, but it's not yet being implemented. Of course, capacity building, training and skill acquisition, partnerships. We need to leverage on other high-income countries that have resources. We can partner with them. And of course, there could be transfer of skills without necessarily moving to those countries. Those virtual programs are training are available. Experts now visit Sub-Saharan Africa. And currently, I'm aware that GOSON in Nigeria, Gynecology Oncology Society of Nigeria, is partnering with International Gynecological Cancer Society, IGCS, to train fellows, and of course, I'm sure, to also start tumor boards and ensure that people are properly trained for prevention and treatment. It's also important that we need to have raised this. So we have to continue to contextualize our evidence. Yes, it is good to import evidence from abroad, but it's also part of the solution is to look at the diversity that our population brings into the etiology of disease. Of course, storage and data will speak and give direction to policy, to investment, to the next activity that we need to have. So unfortunately, most countries in Africa have facility-based cancer registry and not population-based cancer registry that can give an holistic view of cancers that are HPV-associated cancer. So in conclusion, there is limited information on the relationship between different sexual behavior and risk of HPV infection and associated cancer. Non-penile vaginal sex are poorly defined in terms of outcome and impact of risk. So we need to engage in collaborative research, particularly at the population level, in order to understand the role of sexual behavior in HPV-associated cancer across different populations. This is our current collaborations with Northwestern University. First is to look at the epigenetics of HPV-associated oral and oropharyngeal cancer in people living with HIV/AIDS, working with Professor Feinberg and Professor Rob Murphy. Also, we are also looking at generating a pilot data on understanding the epigenetic mechanism of anal HPV in women that have cervical HPV, and of course, conduct a large data or large implementation science on self-sampling for cervical cancer screening in West Africa. So what is also important is that we need to understand how non-penile vaginal sex vary across different population and culture in Sub-Saharan Africa. I would like to end this by thanking the management of University College Hospital, College of Medicine, University of Ibadan, London School, collaborators, the government, and then the leadership and the study participants. Thank you for listening.
Thank you, Imran. Dr. Hu is going to take a few questions here. We're a little bit over time, so this is going to go quick. Li Feng, you want to lead the question and answer?
Sure. Imran, thank you very much for your excellent presentation. It was very interesting. I mean, your research and also very informative and insightful. We have one question through our Q&A through chat. Okay, it's from Rafiq Yusuf, right? And he has two questions, or she, sorry for that. So are there any plans to expand the Ibadan study to the regional and also national levels within Nigeria for better comparison and generalizability? Very good question. Imran?
Yes, there are plans to expand this, and these are some of the issues that for example, the R1 that we just won this year is expanding to all the 6 states in southwestern Nigeria. We're going to recruit participants from about 11 tertiary health institutions. So we are starting gradually. Nigeria is a very big country that has over 200 million people. So we're thinking big, but we're starting gradually.
Excellent. Yeah. Yes. The second question is that what are the implications of the findings from of the Ibadan study for public health and also clinical practice, policy and decision making, and of course resource allocation, at least within Ibadan? And I think this can be also applied to the whole Nigeria and also other West African countries.
Well, I think, well, I suspect that question may have, okay. I think I did mention, but I will emphasize just to say that the main thing is for people to know that this is happening and to understand the health implication of this. So first, there will be need for a policy shift from our understanding of what is sexual risk behavior Second is that there will be need to conduct many other similar studies across the country to understand, for example, whether there are socio-cultural effects in terms of people that are at risk of engaging in these sexual risk behaviors across the country. From penile vaginal sex, we do know that there are regional variation in terms of penile vaginal sexual risk behaviors, but there are no data for others. So getting data will be important, and of course, measuring the proper health outcome. And these will need a lot of advocacy and investment by all, not only government. Even the funder will need to also begin to look into this.
Thank you. So I have a question. So as you probably we all know, it takes time for African countries to really have the HPV vaccine program. So as researchers, we can do we can do little. So what do you think that we can do as researchers, right, to do something at the population and also community level, at least to raise awareness and to educate at least younger people, right, in the sexual practice, and to prevent or reduce the prevalence of HPV infection?
Yeah, thank you very much. I think one of the things is generally that it's also a big issue in Sub-Saharan Africa, based on my little experience, is that there's a disconnect between what the scientific, the outcome of research and what people know in the community in terms of disseminating our research findings. Oftentimes, when people publish, they either publish for academic promotion, they publish because they are interested in the topic, they publish because they just had a grant. But most time, we do focus on how to translate our research finding into policy by engaging people. For example, how many researchers in Sub-Saharan Africa do plan to have policy briefs after their studies? We often ignore this because we think, oh, it's not necessary to the research we have conducted. That's number one. Number two, we also need to collaborate with other researchers from high-income countries who have opportunity for our access to resources and have garnered experience over the years with respect to cutting-edge research. So this is also very limited. A lot of people tend to work in silos. We need to come together. For example, there's nothing stopping us from having a national survey across different sites in Nigeria, coming together as a team to develop a tool that could be used to gather data nationally. And lastly, it's also important that we begin to be sensitive to conduct more research on the outcome of our research. For example, on the issue of HPV 35, yes, this has been reported. In fact, when I was searching literature, as far back as 2012, it has been reported in Nigeria that HPV 35 was the commonest, but nobody has done anything, look into it in terms of basic science to find out. Now, it was this year, early this year, that the NCI is also now advertising, saying that, okay, most of the cervical sample that are found in the African American population have HPV 35. And unfortunately, this has not been covered in HPV vaccine. So these are some of my comments.
Thank you very much. Imran, we're way over time. So we're going to bring this to a conclusion. Thank you very much, Imran. Thank you, Li Feng, for leading the discussion. We also just want to remind the audience that Next month, we have a very special event. It's our Global Health Day, which is Friday, December 2nd. This will be in place of the first Friday seminar that you have today. The event this is really relevant to this discussion today. The event features a keynote address from our friend and colleague, Dr. Satish Gopal, who's director for the Center for Global Health at NCI. And so this is looking to be like a really great program on December 2nd. So we invite you all there. Again, thank you for joining us today. Sorry for going over a little bit, but we got a little bit wrapped up. It was such a great presentation, Imran. Thank you again. And for those of you who registered, a recording of the webinar will be shared via email. And this concludes today's webinar. Thank you so much, everyone.